It is a huge honor today to be interviewing the man, Ziv Simon, who is really the latest rock star in dentistry, giving dentists more confidence in how to extract teeth, place implants. I'm a huge fan of your cases on Dental Town. You have a huge Facebook following, and you practice in Beverly Hills. So my first question to you is, to be successful in Beverly Hills, I know it's like you and Dorfman, you're always good-looking, gorgeous guys. Could a short, fat, bald guy like me even make it in Beverly Hills, or would they just look at me and say, you're not a cosmetic dentist, and walk out?
No, all you need, Howard, is a tight suit and a little bit of attitude, and just do good work, and you'll do just fine. Okay.
So what's it like
I'll
in
hook
Beverly?
you up.
What's it like in Beverly Hills? Is it as rich and famous and elite as we all think it is?
It is sometimes, but really, it's a normal world. We are normal people, flesh and blood. The patients are normal, nice. A lot of the patients are coming from outside of Beverly Hills. So, it's just like any other place in the world. It's just we have a special zip code. And, we feel good about ourselves. So, you're welcome to visit. You'll see how it is.
Well, my identity to 902 Beverly Hills would be more like Eddie Murphy's. That's how I would be in Beverly Hills. Did you ever see that movie?
Of course. Yeah. Of course.
I gotta tell you, I gotta tell you something about that in Beverly Hills. I'm kidding you not. When I was lecturing in China, these dentists were telling me about America,
yes.
And I said, "Well, have you ever been there?" And he goes, "No, but I've watched Eddie Murphy, Beverly Hills. I've seen your country." And I thought, wow, what marketing those Hollywood movies do, and Hollywood is in your neck of the woods. And when you go to other countries, it's like Hollywood is the marketing department of America. Most of their thoughts and views about America are all film scenes that they've seen in all those movies.
Yeah, so reality is that, we wake up at 5 o'clock in the morning. There's no glamour at 5 o'clock, and we work hard, and, we just do the work. It's, good restaurants and beautiful people, but it's still dentistry at its best.
I want to ask you the first question. I like to not talk about anything that everyone agrees on. I like to try to find the 4,000-pound elephant, the disagreement.
Yes.
I wrote the most controversial column I've ever written in my Howard Speaks. I think I've written a monthly column since 1994. And basically what I was trying to put in this column was that when I talk to a lot of older periodontists and oral surgeons who have placed 10,000, 20,000 implants, they like the CBCT. They like knowing where your anatomy is.
Sure.
But they have told me, and a lot of them in private and some of them on podcasts, that, a real surgeon lays a flap, looks at the bone, and 95 out of 100 are replacing a single tooth. Every time you go to a lecture, they're always showing these full mouth rehabs, and that's just not the real market. If you talk to a crown and bridge lab, 95 out of 100 crowns come in one at a time, not 10 upper veneers and all this sexy stuff that everybody talks about. And and the most common tooth you're going to replace is the first molar. And they're like, dude, you got a second bicuspid in front of this hole, a second molar behind it. You got a buccal wall, a lingual wall. If you can't lay a flap like peeling a banana, see that damn bone and bullseye that thing in the middle, you're not a surgeon. And their worry is that if all your surgeries are guided planes through, punching through the tissue, that if you ever do have a complication, you're not going to know how to lay a flap and fix it. So I'm going to open up with that can of worms and let you sink or swim with that question.
Good. No, I read your post. I loved it. I responded to it. Howard, a real surgeon, and we're all surgeons, we're all doctors of dental surgery. Okay, so every dentist should be able to perform surgery. A real surgeon knows when to lay a flap, when not to lay a flap. A real surgeon places implants in a safe place, in the right place, and there's a lot to learn. So, there's an old dogma where, a big surgeon makes a big flap, and, that's not true anymore. So now we have a lot of good technology to make procedures more minimal with some training. You don't have to rely on what you were taught even in dental school. It's not anymore the bullseye, Howard. It's not a bullseye. The bullseye is you decide on it. It's not just in the middle, because it's not always the right place for the implant. So I can talk about it forever, but in reality now, We have very accurate protocols when you need to lay a flap, when you need to do it punched or flapless. And it's just exciting, the opportunities that we have. So I don't think we opened a can of worms. I mean, this is just reality. And
then Ziv, let's start with this then, because I always say that politicians don't need an original idea, because with 220 countries, your idea is already being tried somewhere, and we could just all learn from everyone else.
Sure.
And I learned the most about thinking outside the box by reading 100-year-old dental books written by G.V. Black, or going to other countries. And when I go to other countries like Germany and Korea, 3 out of 4 dentists place implants. And then you come to the United States, and some say that as far as general dentists, you see numbers between 5 and 10%. So
sure.
my question is, so about 7,000 people are going to listen to this. So we got to assume that probably only 400 of them have placed an implant, 500 of them. So what I want you to do is take baby steps with these people. Most of them are driving to work, and they got an hour commute. Okay. And so how do I go from I've never placed an implant to placing an implant?
Right.
How do I start that journey?
Okay, so the journey starts by wanting to place an implant. You see, some dentists are afraid of surgery. Some are, petrified. So first of all, you have to overcome this. You have to want it. You have to see the value. And if you don't know the value, you can't convey it to your patients. So that's the first step in really wanting it. Number 2 is to get educated in implants, and I'm not just talking about the protocols of drilling and doing, just learning the parts and pieces. It's to know the anatomy, know your safety zones, know about nerves and spaces and things like that. And then what I suggest is get comfortable with surgery in general. Start extracting teeth, start doing some perio surgery, get a little bit into incisions, flap design, know the instruments. And then you got your basic skills to start an implant procedure. That's what I recommend. Let's say you're not doing any extractions in your office. You can't move on to placing implants. You got to get your basic surgical skills, get your fingers wet. So that's the first step.
Now, your hands. Could you personally, your courses, hands-on, take them from A to Z? Do you provide the complete training package to go from never placing one to placing one?
Yes, I mean from A to Z, because it's
A to Z. Yeah, I love it.
That's how we do it. I mean the surgical aspect, absolutely. My focus in training is to teach safety, teach accuracy, know what you're doing. If you're just blind and you're just drilling a hole, at some point you'll get into trouble. You may get lucky. A few times. So
are all
absolutely.
So, what is your website for perio90210.com?
So that's my private office website, and you can learn a little bit about me. But really, the way I do my training is through mentorship and hands-on courses. So most dentists that I work with first sign up on my website, SurgicalMaster.com, and then they subscribe to my email list. They're getting an email and a video every week, and then we start engaging and starting a conversation online, and we take it from there. The dentists that I work with, Howard, you won't believe the results that they're getting. They're emailing me excited, and when I meet with them, they have almost tears in their eyes, the things that they're able to do. And sometimes better than a specialist.
Well, let's go to specifics. Is this a one program, like a 2-day, 3-day, or is it a curriculum like 3 2-day weekends, or? Well,
at the moment I have courses at USC that teach perio surgery. The full range of perio surgery, from soft tissue grafting to crown lengthening to soft tissue management around implants, and then computer guided surgery that goes over the basics all the way to advanced. And then I have my private mentoring doctors that I work with, and I set them up, and once they're up and running, they really don't need me anymore. That we just keep in touch. And of course, we have the online training as well.
So that is amazing. And so what would you recommend the first step to get your curriculum at USC then, or
the first step
or would you just go
implants? For
Yeah.
implants,
Yeah.
for implants, UC has a curriculum that I don't run at the moment, but that's a really good program. Get some basic training from your implant company. Get some just the experience understanding the different burrs and sequence of drilling, and get some surgery training. We know that periodontists are very qualified in soft tissue management. That's going to help you get better results. So really all of the above, Howard.
So you like the USC program?
I love it. I teach it. Absolutely. I love
And
it.
so what is this? So what is it? Is it as a 1 weekend a month for a year, or is it
the implant program is a continuum. There are several programs, weekend programs throughout the year. That's a good program to start with. But really, any program will give you the basics. The key is what you do with it, and that's where I come into play, because my teaching is more real life, and I'm a real person, and we keep everything simple and safe. So that's a really good program to start with.
So help this dentist out. My whole motto in 1998 when I saw the internet come out, I said, no dentist should ever have to be alone, and this internet can connect all of us. There's only one out of 1,850 of us in America as a dentist, and we could all talk together. And so this dentist is alone, and they're going to the dental convention, and there's an implant booth on every corner. There were 275 implant companies at Cologne last year. Is titanium? Is there any difference between a $500 implant and a $100 implant? So specifically, what's the criteria for this individual dentist driving to work right now who's never placed an implant? And they don't want to own 5 systems. Specialists have to own 5 systems because they're referring doctors. But this is the spoiled general dentist. What system would you recommend?
Okay. That's what I recommend. I recommend a system. First of all, titanium is titanium, and there are different implant designs. So I would choose a company that offers a range of implants, from taper to parallel, platform switching, and good restorative options. Number 2, and that's probably the most important, you want to pick an implant company that is not going to go out of business in the near future, because we now have problems of knockoffs, and go look for the implant and implant space different parts of the world. So pick a reputable company that has FDA approved product lines. And, it doesn't have to be a brand name. I'll be honest. I use brand names. I'm a specialist, so I use whatever my guys want me to place. But it does not have to be a brand name. All these implants, I've tried them all. They all work the same. It's about the technique and how you place them, and even before how you plan them first. So it, for the general dentist is just starting out, don't buy $50,000 worth of inventory and a million components. You'll have it sitting there. It's a waste of money. It'll confuse your assistants. So just start with the basic startup, which is like 20, 30 implants, basic components, and educate yourself about how to plan for implants, how to place implants, and just do it. Get started. Because if it's just going to sit there, it's, you haven't achieved anything.
This person's all alone. Can you give any specific recommendations? Can you give any specific implant companies?
Well, I can start counting companies, but, I use the 5 major brands.
Okay, what are the 5 major brands?
5 major brands right now in the United States.
Follow all those criteria. FDA approved, won't go out of business, do research.
And they have a track record of good customer service. So we're looking at Nobel Biocare. We're looking at Astor, which is basically Dentsply. We're looking at Straumann. Looking at Zimmer, BioHorizons. There are some of the Korean companies that are getting up there.
Is Zimmer BioHorizon, or is that 2 companies?
No, Zimmer is different. Zimmer is different.
Oh, so Zimmer is different? And BioHorizon. BioHorizon was Carl Misch's.
He's part of it. It's not his, but he's definitely part of it.
Are you saying Zimmer is BioHorizon? Zimmer BioHorizon?
No, Zimmer is not. Zimmer is now combined with 3i. Zimmer bought Biomed 3i. So if you buy 3i or Zimmer, it's the same company. And these are the major 5, 6 and BioHorizons. These are the major companies right now.
So Noble, Astor, Straumann, Zimmer, BioHorizon. That's 5.
These are the major companies that are out there. have a good track record. That's not to say that all the other companies are no good, Howard. I'm not saying that because I don't want to have phone calls after the show. Why didn't you mention our name? But really, the reality is the company has to be strong financially, has to have a good backing behind it. Each company buys the other one. So you don't want to be stuck with hardware in your patient's mouth and the company is out of business. So I think that's something we owe our patients.
But I think the reason I'm up to 7,000 views per show is because you will get phone calls after this because I like to ask. I like to be a dental journalist. I like to ask the real questions.
And that's okay.
And I got to go back. My job is not these questions. It's not that I don't know the answer, but I have to ask the questions that I know these individuals are thinking. You just rattled off 3 words, and I bet you half the audience didn't know what they were. You said the implant. You have to have a system where they're tapered, parallel, and platform switching. So you need to go back and explain what's the difference between a tapered, a parallel, and what is platform switching.
You got it. So Howard, now we have so many clinical options for our patients. We have immediate loading, we have delayed loading, we have so many restorative options all on 4 and a single central incisor. So the reality is that the shape of the implant and the threading, whether it's very light threading or aggressive threading, makes a big impact on the initial stability. So if you're using a system that has aggressive threading and a tapered design, usually, generally speaking, these implants will achieve higher initial stability, and that's the stability of the implant once you place it in bone. That gives you more options for immediate load, immediate provisionals. Okay, so that's the shape of the implant. So you have to have a company that has all these features. Okay, doing okay so far?
Yes.
Okay, awesome. Number 2, the platform switch. If you think about the old implant design, and old is not necessarily good, okay? We all know that. So we think about the platform of the implant, and if the restorative component is slightly smaller than the platform of the implant, we call it a platform switch. Okay, it switches from a wider diameter into a smaller diameter. And what it does, and by the way, it was never proven in literature. It amazes me. What I'm telling you is not scientifically based, but that's the trend of the market. When you use a platform switched implant, bone levels are much stabler because the micro gap, the small little gap between the restorative component and the implant, is farther away from the bone. It's towards the middle of the implant. So you're decreasing the inflammation, and that in turn reduces bone loss. Number 2, when you have an implant that has a narrow neck, if you will, you have more room for soft tissue, and the soft tissue stability is better. So I personally switched basically all the systems that I'm using the feature of platform switching because personally I'm getting better results, and that's really the trend of the market right now.
So the platform switch is the abutment is wider than the implant. It switches
actually that the a little bit in reverse. In the implant, there is a little bevel. If you think about the platform of the implant, which is the most coronal part of the implant, the platform itself has an inward bevel. So anything that you connect to it, by definition, is a little bit smaller than the circumference of the platform. So that's called a platform switch.
So I want to ask you another huge controversial thing. You're a periodontist first and foremost.
Yes, I am.
So humans aren't born with P. gingivalis, right? The baby comes out, it does not have P. gingivalis, correct?
It comes germ-free, absolutely.
Yeah, so it picks up this contagious disease somewhere. So
it does.
So one of the
P.
things,
gingivalis is the least. There's much worse than that.
Yes. So I want to ask you 2 bizarre questions.
Okay.
Can a dentist really treat a woman every 3 months for perio on 3-month recall for 10 years and have never seen her husband? I mean, I'll give you a crude analogy. Could I treat a woman every 3 months for chlamydia for 10 years and never once get her lover in there? Can you really?
Okay.
Can you be kissing a trash mouth in bed every night while you're getting 3-month cleanings at your dental office, or should a dentist say, no, I'm sorry, I need to see everyone you're trading saliva with?
Yes, I mean, if your spouse is good looking, then yes. This is the story, Howard. P. gingivalis, AA, all the we call them periopathogens. They're not STDs. They're not STDs. So, like you said, a baby is born germ-free. As it passes through the birth canal, it starts to acquire bacteria and viruses and fungi. Okay, sounds good. I'm actually having a baby on the way, so I'm thinking about that. So the story is the first inhabitants of the baby's oral bacteria usually comes from the mom. Usually comes from the mom that basically kisses the baby and cares for the baby. So that's the first encounter with all the periopathogens. Now, these babies, these kids and later on adults can carry these bacteria and develop perio disease, and so do the husbands or the spouses, boyfriends, girlfriends. But the reality is there's something called the immune system, and if your immune system is not susceptible to having periodontal disease developed, you and me can have P. gingivalis in our mouth without developing perio disease, because there's a balance between the bacteria and the immune system. So it's not as simple as transmitting an STD. It's a little bit different. It's a good way to get the husband in, by the way. It's a good way to get the husband for treatment, but it's not as simple as it sounds.
Okay, well, this is a several-step question trying to get to the final answer. So it's a gram-negative facultative anaerobe. It can't live in oxygen, correct? So
prefers to leave it in the pocket. Yes, sir.
So when this baby is edentulous and has no teeth, you couldn't transmit it from the mom to the baby because there'd be no place for it to live. Is that correct?
Correct.
So then it's only when the baby's first 2 baby teeth come through that there'd be an environment to transmit this disease. Sure. So then my question is this. This convoluted question was trying to get to this. I had to do all these additional steps.
No worries.
My crazy question.
No, it's a good question.
So then, most of the people that need your services, they had gum disease and decay and all that stuff. And I see dentists pulling out all these teeth and then placing implants. Wouldn't it be better to pull all the teeth and let them go edentulous and have no environment? All those bugs are gone, and then go back and place implants? And if you went totally edentulous to a denture, are you now free from P. gingivalis? And then when you place implants after that, would you have less peri-implantitis? And is that the world's record for the most questions in a single question? And how are you going to answer all this?
Howard, I love your question. It's right to the point, and it's a great question because in the absence of teeth, by definition, there's no perio disease. Okay, so technically, once you extract all of the teeth, the patient has no more gum disease. So far we're clear.
But are the bugs gone now? Did they all die because they had no house?
That's a great question. We have to ask a microbiologist. I'm a clinician, but I know a little bit about bugs. The microbiota in the mouth is complex, and I think those specific periopathogens are gone, or in a significant amount where they won't cause any damage. The reality is, once you start creating a patency between the oral environment through the gum tissue and bone, all of this is going to change. All of this is going to change because we're not living in a bubble, and we're going to start acquiring bacteria from the environment, like you said, the spouse and whoever else. And patients with periodontal disease have the same type of bugs that patients have with peri-implantitis. And we see it in let's call it the mixed dentition for an adult. When you have patients that have natural teeth and implants, the bacteria sampled from both is the same. So one that has a lot of peripathogens around the teeth will have it around the implants. Interestingly enough, that does not mean that the implants will fail, okay, to add to the complexity, because I don't see more failures in perio patients compared to patients that just broke a tooth and had it replaced. So there are some things we don't know. Now we're looking more into, which is interesting, not so much the bacteria, but also the viruses, because there's more research coming out of USC that shows that viruses play a role in periodontal disease through a complex mechanism where they cause an immune dysregulation and basically helping the bacteria create more damage. So bacteria and viruses are pretty good friends in working against us. So sometimes antiviral medication is also a good option. Did you know that?
Yes, and I did a podcast with Rolla Christian, and
Okay.
we were talking about how there's a new study showing that in decay, Streptococcus mutans is working with candidiasis.
There you go.
And that's one of the reasons the plaque is that they're working hand in hand together. Isn't that bizarre?
Yeah, it is bizarre, and you see that's a misconception. And one misconception that a lot of dentists and sometimes patients have is that the enemy is the bacteria, and that's true. The bacteria is enemy number one, and the enemy number two is our immune system. The immune system is a double-edged sword because the ravages of periodontal disease is not because of the bacteria directly. It's because of the immune system responding to the bacteria causing all this bone loss around teeth and implants. So it's really complex, more than what we think it is. And if a patient thinks, give me some antibiotics, let's get rid of the disease or extract all of my teeth, it'll go away, not the reality, okay? So it's much more complex than what we think it is.
So back to those bugs, there's a lot of products in the market that put little chips under the gums and pockets, things like that. Are you a fan of any of those on
Yeah, I'm a fan. I'm a fan of everything that can help. I don't like the abuse. I don't like the, using it just to, generating income. That in itself is, generating income is a good thing in itself, but we're talking about products like, Arrestin as an example. It's a great product, but I personally use it in very localized perio defects. If a patient needs, 200 applications of Arrestin every time it comes for a cleaning, it's cost prohibitive.
Now, that's a tetracycline, right, Arrestin?
That's minocycline, which is the same family.
Minocycline? Okay, I should... What do you think about my low cost technique where you just take a tetracycline, the capsules, and pull them apart into your dapping dish and put just a little bit of water and then just brush that into the area, just brushing tetracycline from a pill out of the refrigerator. Is that not good?
I'm not saying it's not good. I'm not familiar. I don't know it has to do with pharmacokinetics, and I'm not so familiar with the Arrestin, but they actually compounded it into microspheres that stay in the pocket for about 3 to 4 weeks. And I'm not sure just the powder of tetracycline can do it. And by the way, it's hard to get tetracycline in the United States, as you know.
Yeah. So then my last question is the other very controversial issue. There's people out there swearing with Lanap that when they're going down there with a specific laser into these deep pockets that they're killing bugs and getting healing. Are you a Lanap fan or?
I don't use Lanap. I don't use Lanap. I don't use the laser for that purpose. And I've seen some great results, Howard. I've seen some research. I've seen some pretty amazing cases with Lanap. And I have to say that's something that I have to educate myself more to give you a good answer. It's like it becomes a religion. Either you're a Lanap fan or you're a hater. All I'm saying is I need to learn more. I need to know more. Not necessarily research. Research is, the fact that something was not proven doesn't mean it doesn't work.
Right. And the older I get, the more humble I get. Because at 52, you just realize that we're dealing with imperfect data. They're not going to know half of these answers for 1,000 years.
Listen, even if they studied Lanap or any type of procedure in dentistry, by the time the research is complete, it's like 3 to 5 years. Then by the time it gets published, 2, 3, 4 years. So what you're reading in an article is data that is almost 10 years old. So, by the time you read the article, there's new stuff and you already proved yourself wrong. So we're clinicians. We're going to test it on our patients.
So I'm going to go back to the very beginning of this interview. This girl's driving to work. She's never placed implant. You gave her names of a system, but I know a lot of them are talking on Dental Town. They're like, well, help me pick the lowest hanging fruit. What would be the easiest first implant? I don't want to do a number 8 on a hot.
No, don't do it. Don't do it.
And what should I be more afraid of? hitting the sinus, replacing a first molar on the upper, or hitting the inferior nerve on the lower?
Okay.
What's the low-hanging fruit?
Okay.
Knowing that the most common tooth missing is the first molar.
Yes, and you hit it right, just right, and that's what I call the money tooth. Okay, that's the tooth that is the most treated in dentistry. Starts as a cavity, goes onto a three-surface, a crown, a root canal, an apico, and ends up with a crack and an extraction. So you'll read about it in my book, how to extract the money tooth, hopefully soon. So that's the lowest hanging fruit, and it's low because it's the lower. And typically, and I'm generalizing, typically if you performed a reasonably atraumatic extraction and you preserve the site, you place the bone graft, and you have some bone volume, and you didn't lose too much of the vertical component, typically it's a safe area to practice. It's away from the aesthetic zone. You have a pretty good leeway of mesiodistal space, hopefully also buccolingual. And that's why I recommend starting and get comfortable reflecting a flap, get comfortable positioning your implant, use some type of guidance. It could be a conventional guide, it could be a computer guide, it can be some more sophisticated computer software if you'd like. Okay, that's not just for specialists. And start with that. Place not too many, 5 to 10 implants in the molar position, first molar position. Don't go to the second molar. The second molar is a different animal, Howard, okay? In the second molar position, the inferior velar nerve is at its highest position. It's more lingual. You have lingual concavities. So first and second molars are totally different, okay? And sometimes you're running into problems with actually not enough restorative space, not enough room for your drills and your hardware to drill properly. So first molar, not the second molar.
And okay, so this you're trying.
I can also give you long answers, okay?
So you're trying to describe. Our goal in this interview is try to get the other 9 out of 10 general dentists to place their first implant. So to pick the lowest hanging fruit, would you go first molar? Would you go mandibular or maxillary?
Definitely mandibular, and over 90%, maybe 95% of upper first molars, you will have some type of sinus proximity. You're going to be dealing with softer bone, less initial stability. And why start with that? Why make your life complicated? Okay?
And would you start? And with this patient, should it be your mother or mother-in-law?
That all depends. I love both. So,
but my first sinus lift was my mother-in-law. And but anyway,
how'd it go? How'd it go?
It was great. She's so amazing. She was so sweet, and she wanted it, and she wanted me to have someone to try it on. And
that's good. And she was okay before and after.
Yeah, and she's still alive. So we're talking about a mandibular first molar. What would be the next lowest hanging fruit? Would it be a second mandibular, second premolar, or is the middle?
No, it's going to be it's actually going to be a maxillary second premolar for a very simple reason. As you move in your implant training and your skills and your confidence, you want to actually move to the maxilla as soon as you can, because it's a type of bone that responds completely different than the mandible, obviously. And I don't like to start with a number 5 or 12 because, or I don't recommend starting because the upper canine has a distal angle, and this is a classic mistake. A lot of the beginner implantologists don't take it into account, and you know what happens? They start to engage the root, or they get dangerously close. So start with like a number 4, number 13. You still have enough leeway. And basically, once you do that, place a couple of lower premolars. Be careful of obviously the mental nerve, and work your way up to start doing some more aesthetic work.
Okay, and
again a different animal.
Okay, and CBCT. What any of those that you like is
Are
they all the same? Do they all work?
As far as I'm concerned,
CBCTs.
Yes, they're different, Howard. They're different. They have different bells and whistles. They have different levels of quality of image and different images that you can create from them. The reality is, all we need is the final product. For me, I need the DICOM images or the DICOM files. And all you need to see is the anatomy, because the anatomy is the life. The anatomy is the most important thing. So as long as you can see anatomy clearly, and you can identify nerves, spaces, and outline of bone, and maybe bone quality, you're good. And all the CT scanners on the market do it.
Now,
Okay.
Ziv, you're a periodontist, so
Yes.
I want to ask you the truth of this. Am I, I like street smart dentists. I
Okay.
don't like book smart dentists. And
Okay.
I don't think you need a $150,000 X-ray machine. You need access to one.
Sure.
Is it rude to call up your periodontist and say, "Can I send my patient over and use yours?" Or what would make it kosher to do that? Would you like? You say, "I'm going to do the." Is this, success is about how willing you are to have uncomfortable conversations.
Absolutely.
A lot of people are just
No,
right. Would it be rude? Give them terminology, call up your periodontist, and say, "Look, I'm going to get into implants, and I'm going to try mandibular molars 19 and 30, maxillary second bite 413. Ziv, I'll give you all the rest. I don't want to buy a $150,000 X-ray machine. You have one."
Assuming I don't have one. Assuming I had one.
Well, explain why.
I have one.
So see, you're so street smart. So why do you not have one?
Okay.
You're the most famous Beverly Hills implantologist on earth. Why did you not buy one? Because you're just that street smart?
It's nothing to do with street smart. You see, the way I see it, and there's nothing wrong with having a scanner in your office. Once you buy a scanner, in about 3 to 4 years after that, this scanner becomes obsolete. Now, are you going to buy a new scanner every 4 to 5 years? Are you going to keep upgrading it? I think the answer is no, because it's a pretty big chunk of money. And I have 7 operatories right here behind me. I prefer to use these operatories for clinical work. So if I have a dedicated radiologist, which is just 2 minutes away, and I can send my patient there, they're treated professionally. The positioning of the patient is perfect. I get the results within an hour. I don't see this as a problem. I'd like my office to be clinically active and not doing imaging. Now, the other thing is, and that's, again, we're talking about the elephant in the room. Once you have a scanner in your office, Howard, you got to use it. If you don't use it, why'd you buy it? So I think it puts a little bit of pressure on the clinician to use it, and somebody who is borderline unethical may have some issues with that. So I think I don't want to have a monster that I have to have some pressure on me to use it, and I definitely have the volume to make it worth my while. But the space can be used some other ways.
Is that the true answer, or is it really that you saved up $100,000 and your wife wouldn't spend on Rodeo Drive on purses and shoes?
My wife would be happy. We can ask. I have a beautiful wife that deserves things like that.
So, ladies and gentlemen, this guy is so street smart. That's what I've been saying. Yeah. I mean, you need access to a CBCT. You don't.
Yeah, you don't need it.
So then the next.
You call your specialist. How would you ask me about? Can you call your specialist? Your specialist would love that. I think I would love that.
That's what I think. That's what I think, because they're trying to start conversations to meet people. That's why they joined the dental society. That's why they're always hanging out at study clubs.
Yeah,
and they're afraid to call you to go to lunch because they're introverts, scientists, engineer, physicists, geeks, just like you are. So it's two introvert people afraid of each other. So I think they want a relationship.
Yeah, do it.
Just
absolutely.
Pick up the phone.
Call your specialist and let him help you.
So I'm going through these baby steps. So they get a CBCT, they export on DICOM file. Let's talk about on these first 10 implants, mandibular molars 1930, maxillary second bite has 4 and 13. Would you recommend a punchless surgical guide, flapless experience, or would you say, no, it's time to man up, be a surgeon, and lay a flap?
Yeah, again, laying a flap has nothing to do with being a surgeon. Laying a flap is an option that you have that we have very specific guidelines. If this is your first lower molar implant, so what I would do, I would take the time, study the scan, study the location of the nerve, study the dimensions of the ridge, but also see if this ridge is in the right position, and maybe take some models and call your local specialist, call me. Show me your case, and that's what I do with a lot of the doctors that I mentor. I always tell them, don't jump the gun. Get all the information. Give me a call. Let's do a Skype one-on-one. Let me see some of the models. Let me warn you about some pitfalls. Let me prepare you for the procedure. And then part of it is looking at the soft tissue. Many times in the posterior mandible, there's not enough attached and keratinized tissue. There's not enough good tissue to work with. So if you punch through this tissue, you're actually creating damage. You're just messing it up. So I would say study the case, look if you have enough space, and then ideally order a surgical guide from your lab that will have some type of access. So when you drill, you know that you're in the ballpark through what we call a screw axis positioning. And, take your time. Don't rush through it. Don't book half an hour. Book 2 hours. Give yourself ample time to get the patient comfortable, do it properly, suture and all this other stuff, and then, you'll be in good shape, and your patient too.
So what you just said was very profound. If you're going to go do a punchless, flapless deal, but your hole eats up the whole radius of the attached gingiva, and you're leaving buccolingual margins and removable tissue, you
why
just
do
messed
it?
up.
Why
You just
do
messed
it?
up.
Why do
But
it?
you just did a big segue to, you just said suture it up. When I think of you, I mean, you're elite. I mean, you're the whole package. You're just charming. You're smart. Your cases are
That's so
stunning.
nice.
But your suturing is kind of at a freak level. I mean, you take suturing more serious than anybody I know. And I mean, you look like, really, you're like Picasso when you're sewing, man.
Okay.
Why do you take suturing so serious? And is this a big part of being a surgeon?
Yes, suturing, you touched upon, one of my passions. And suturing has been a problem since I started teaching. I've been teaching forever. And every dentist in every course, or a lot of the dentists tell me, we have problems with suturing. We know how to do big surgeries. We're comfortable doing implants. We're doing sophisticated cases. It comes to suturing. We have two left hands. And it bothered me for so many years, and I was always emphasizing suturing, but about a year ago, I started a new suturing system, teaching system called the zPad. Okay, so I created a physical device. Do you want to see it?
Absolutely.
Okay, let me see if I have an example.
A lot of people will tell you it took longer to suture the surgery afterwards than it did to do the surgery.
Yeah, let me show you an example.
How many times have you heard that?
Yeah, that's a great question, and we just tested it. So this is called a zPad, okay, and you can guess that this is a size and shape of an iPad, but it's a zPad because my name is Ziv. And basically what it is, it's a game. It's a game where doctors that are training in suturing go through different tasks. Let's call it basic training in suturing. And at the end of the course, at the end of the curriculum, they get it. They know how to suture. They get confidence. And, they call me and they say, you know what, I know how to suture. And I put it to the test, Howard, you won't believe what I did. I took somebody who's not a dentist. He's never touched a handpiece. He doesn't have a dental degree. And I took this guy, nice guy, I put him through the suturing training. And I put him together with all the dentists. And after the course was 7 hours. After 7 hours, he got results on the zPad that are better than some of the dentists. Can you imagine that? So this stuff is effective, and really, I'm going to come out with this hopefully in the next few months, and we'll change the world around. We'll teach dentist students how to suture properly, because you can have a great surgery, and at the end of the day, you'll mess it up because you didn't suture properly. So I came up with laws of suturing. I came up with tips and tricks, and everybody can suture, even you.
So talk about your new book, which is true. You talk about the molar, the money tooth.
The money tooth.
Which is the first molar.
Yes, sir. Lower molar.
In fact, the lower molar?
The lower molar is the money tooth. It's the first one in the mouth. It's the one that has those deep grooves that need to be sealed, that develop caries, and basically it's the one that is missing for a lot of patients, maybe a lot of dentists as well.
So talk about your book. When's it coming out?
Okay, it's almost done. It's going to come out soon. Basically, this book is going to describe a protocol or protocols on how to extract this tooth. And if you think as a dentist that extracting a tooth is just grabbing the tooth with forceps and ripping it out, it's not reality, because now we're thinking not about the extraction, we're thinking about the next step, which is an implant. So if you're going to damage all this surrounding, you'll pay for it later on. Your patient will pay for it. So what I do in the book, first of all, I describe the money tooth, and I describe why I call it the money tooth and why it's important. But then I go through different protocols, starting from Plan A through Plan B, C, all the way to E, and I explain each step of the way. And basically, it's my logic. It's not a picture book, but if you have some trouble with extracting lower molars, I think that'll be a good, interesting book for you. And I look forward to your feedback as well.
Well, you know what? I try all the time. You post some of the most amazing cases, your videos. I'm always trying to get your content on Dental Town. Maybe that should be your first online CE course on Dental Town, and when they pay for the course, they get a copy of your book or something. Or
let's talk about it. Let's talk about it. Absolutely.
We just passed 200,000 members. We have I think the smallest country we have. We have dentists in every country, and we're coming up on 4 million posts. And I'd give anything to get more of your amazing content on there. But I want to ask a redundant question. So a lot of dentists, they place that implant, and it's just one stitch distal to the implant, one stitch mesial to the implant. Is that okay, or is that really not enough? To go back and talk about,
sure.
Does it just all work, or do they need to take suturing a little more serious?
You see, that's the thing. Sometimes that's all it takes. That's the beauty of suturing. The suturing is not a dogma. Suturing, it depends on what the tissue needs. It depends how you need to stabilize the flaps and stabilize the tissue or stabilize the graft. So sometimes that's all it takes to suture one in the posterior, one distal, one mesial, and that's enough. And I don't have any problem with that. And really, the proof is in the pudding, Howard. If you finish your surgery and you put just 2 simple interrupted sutures, and it works great, keep doing what you're doing. Don't change the winning formula. Okay? So I don't have any issue with that.
I want you to talk about getting rid of some guilt some of these dentists have. A lot of times a person comes in, they got a toothache. We do the financial arrangement. I'm in Phoenix, Arizona. I'm not in a fancy suburb. So in my office, about 3 out of 4 people with a toothache will say, okay, I'll go with the root canal and crown, which is going to be about $2,500. And then 1 out of 4 say, I ain't got that kind of money. I just want it pulled. But when we pull a tooth, we're always wondering, should I be bone grafting that? Because some people say, if you bone graft that and they don't go back and get an implant in 6 months, you just wasted time and money. Other people are saying, no, that's not true. Will you talk about when this dentist driving to work right now needs to be thinking, when do you bone graft after an extraction?
Great question. Common question for dentists, common question for patients too. You know, if I'm not planning an implant, I'm planning a bridge or no replacement, should I bone graft? So when you think about extraction, it's not the extraction, it's thinking what's going to come next. And if you're not planning an implant, this particular patient may be able to afford an implant down the road. So by grafting the socket, you'll be able to preserve some of the ridge. You'll get some resorption no matter what, even with grafting. So my personal preference is graft every socket, except for third molars, of course, and preserve the socket. Even if you're having a pontic site, you still want this pontic site to have some type of dimensions. You don't want to have a long pontic. So grafting is recommended for any extraction socket. In my recommendation, that's what I do. And if the patient objects to it, financially, then there's nothing you can do about it. But you should definitely talk about the benefits.
You're a street smart guy, and like I say, I'm truly your biggest friend. I don't know. It's either me or Delia Tuttle. I don't know who thinks you walk on water more, me or
I'm a
Delia
normal
Tuttle.
guy, Howard. You know that. I'm a normal guy.
But when you talk about bone grafting, some people are centrifuging blood, and some people always lay a membrane over it. Is there a simple bone grafting, or do you need to, are you buying human bone? There's bone putty, or are you harvesting it from back where their wisdom tooth is? Can you talk about bone grafting?
Yeah, absolutely. You see, that's where we have choices and options, and there's so many great things that you can do. I can tell you what I do, but generally speaking, the type of bone graft is important, and we try to use either an allograft material, which is human bone, or xenograft, which comes from an animal. Both are fine. I don't like the plastic materials, the alloplasts, which are gaining some popularity lately. And the simplest way to do a bone graft is to pack the socket, assuming you have all the walls, and you really don't need a membrane. Okay, all you need to do is place a piece of collagen plug or even gel foam on the occlusal part of the socket. I call it compartment grafting. It's pretty involved in my teaching. I talk about how to do these compartments, and that's simple. Now, you'd like to add some of the patient's blood, which I do, and spin it and isolate some high concentration of platelets to make it better. If you have the opportunity, if you have the options and the knowledge, do it. It's much better. I get better results. But what did we do before? We just kept it simple. So you can go from very simple bone graft and collagen all the way to using, harvesting the patient's own bone is just going to create more pain for the patient. For a socket, it's absolutely not necessary, in my opinion.
Okay, go specifics. How does this dentist driving to work get a hold of human bone?
Okay.
Just go down to the cemetery and dig up one of the coffins?
Well, yeah, you can do that too, but you get in trouble. So what you can do is just open a dental journal. Open whatever your local society dental journal, or open a professional journal, or just look in your mail in the office. Every day you'll get a promotion for some type of bone graft. Call your dental supplier. Call Patterson. Call Shine. Call the other companies. They have bone. Okay, they'll tell you if it's human bone or not. It's obviously FDA approved. Now you have to look at the particle size. Okay, the size of the smaller particles, in my opinion, makes a difference. So we like to use a particle size between 0.25 and 1 to 2 millimeters. That's going to be the range. And you take this bone, and it's obviously a one-time use. You open it up, you used it up.
And how much is something like this going to cost? And do you charge the patient for the bone graft? And
sure, absolutely.
And what would this dentist driving to work right now charge for that? Would it be equivalent to like the same cost as the extraction, or half the price of the extraction, or is there any ratio there? Or
that's a great question. It's a practice management question. Okay, how you should create your fees. In my opinion, if you charge just for the material, you're basically losing. Okay, you're going to lose income. So what you're charging for when you say bone grafting is the process of bone grafting. It's a separate procedure. And what you need to factor into it is the cost of the materials, meaning the bone graft, and if you need a membrane or let's say a collagen plug, you factor it in, but you need to charge a little bit extra for to also make some profit and make it worth your while.
So Ziv, are you saying
the ratio? You wanted to know the ratio?
Yeah.
The ratio should be, in my opinion, at least 2.5 to 2.5 times the cost of the bone graft.
Of the actual bone graft,
depending on the complexity of the case, but around 2.5 times.
You are one street smart dude. And so, Ziv, you're saying there's really no national brand on an allograft, that this is a local play from your local journal because the bone is in your backyard, your own state, community? Is that what you're saying?
No. Yeah, that's you just look for, again, a reputable company.
Can you name any?
Sure. You can use BioHorizons. You can use Zimmer. You can use Nobel's bone graft.
Okay, so all those companies that you mentioned, they sell bone grafts.
They sell bone grafts, of course. And by the way, some of them make the bone graft in the same place, and they just make it private label.
So I want to ask you, there's this new concept. I don't know if you ever saw the movie Fargo. It's one of my.
I love it.
Where the last scene is they put some human in
somebody.
a wood
Yes, of course.
Well, Megagen just came out with this Fargo wood chipper where when you extract the tooth, you throw it in there and it pulverizes it for mush.
Yes.
And they're using that. Is that bleeding edge? Would you recommend that?
I do that, Howard. It's awesome.
You're using the Megagen blender?
Not Megagen. No, I use an Israeli company called Cometa Bio.
Spell it.
Cometa, Kometa, and a separate word, bio.
Is that so? That would be the .com, Cometa.
Cometa Bio.
KOMETA
.com. I think it's .com, but you can just Google it. Let me tell you my experience and the idea behind it. It's called dentin grafting. So it sounds crazy, but it's been used for a long, long time in dentistry, mostly in Korea, also in Israel, where I'm from.
You're from Israel?
I'm from Israel.
Where you
Isn't
were?
it obvious?
No, Tel Aviv or Jerusalem?
I'm from Tel Aviv. I graduated Tel Aviv University and then University of Toronto.
I did not know.
Yeah.
And so you went from Tel Aviv to Toronto,
Yes, I
then to
did.
Beverly Hills?
Yes, sir.
Man, you lived in 3 different
Yeah.
corners of the world.
Born in Germany, believe it or not, so 4 countries.
Born in Germany.
Yeah, that's
Wow.
a story. That's some story.
Well, my bucket list on my podcast is to
Okay.
interview someone from every single country, and I've
Okay.
done already done like a dozen countries. I so want to interview someone from Israel.
But Howard, do I count for 4 countries or no?
That's right. Okay. You'll count. But
Okay.
so
this
this
you want to
pole
talk about
graft-
dentin grafting because
No,
that's,
I want to talk about that machine because when
Sure.
I first saw that, I first thought of Fargo, but then I
Sure.
thought to myself, man, wouldn't that be awesome if this
Sure.
really is the deal?
Sure. So this is the story. Fargo is grinding the whole person. For people that didn't see the movie, go watch it. It's awesome. It's so funny.
I love the
hilarious. I want to
accents.
visit. I want to go there one day. It's an actual place, right?
Yeah, I've lectured there.
Okay, so the story of those grinders, we are grinding tooth material. And what is tooth material? It's mostly dentin, a little bit of enamel, and obviously cementum, okay? So the idea is if you ground the tooth structure down, you're getting small little particles. It actually looks like a bone graft. Number one, you're doubling the volume of the tooth. So if you ground the tooth down, you're getting double the volume. That's just a basic mechanical principle. Number two.
You can teach that principle by buying a chocolate shake at McDonald's and then
Yes.
letting it go to room temperature. The volume's half down because what they pulverize it
Right.
to incorporate 60% air to lower their cost.
Yes, but I don't want to go to McDonald's.
But so when you pulverize this tooth, it doubles the volume.
Doubles the volume, so you're getting much more. Now you can take a wisdom tooth out. Imagine how much bone graft you're going to get. So if you think about what happens when a tooth comes out, basically traumatically, and you reimplant it, why do these procedures work? Why does a tooth that gets reimplanted stay there for like a good 20 years until it gets resorbed and gets other problems? Because the tooth gets ankylosed. The bone attaches to the tooth. So bone and tooth are a perfect marriage. So if you take this tooth and you pulverize it, now you have each particle, let's say hundreds of them or thousands of them in a socket, gets ankylosed to the bone, you're getting the fastest healing. And guess what? You're getting the biggest dimensional stability of a ridge, which is what I saw. I was amazed to see that. The bone grafts that we're using, all the conventional bone grafts we talked about, let's be honest, they resorb. You look at them 2-3 months later, six months to a year later, you see dimensional changes of the ridge, whether there's an implant there or not. If you look at dentin grafting, these ridges stay hefty, they stay stable, and I believe, and we have now histological evidence to show that each particle is basically surrounded by bone directly. Now you add the hydroxyapatite from the enamel, you're getting some more mineral, and this bone is ready to be drilled in about 6 months later. 6 weeks later, I'm sorry, not 6 months, 6 weeks.
So Ziv, then why did you talk about bone grafting? Why did you first mention allograft? Why did you not first mention dentin bonding or dentin grafting?
Dentin grafting, okay, that's the reason, because we have some restrictions. At the moment, we cannot use teeth that have root canals. Okay, that's a bummer, because a lot of the teeth that are being extracted are endodontically treated. And the concern is, and you can clean the gutta percha out, that's easy. But the concern is that in the dentinal tubules, there could be some heavy metals and some toxins that will then be embedded in the socket. So we still have to find a way around it. And I'm just, putting out a shout out or a call out to companies or maybe us dentists to organize and maybe get dentin xenografts, basically dentin from animals that gets processed. So I don't have to take the patient's own tooth, and I can just buy it off the shelf and use dentin graft as my bone grafting material, or not bone, dentin grafting.
Well, I know when you pull a tooth and you have in your hand,
Sure.
you can take your 300 RPM night tie and put on like a 45 and
Sure.
take out that root canal in
That's
2
easy.
seconds.
That's easy.
Would that be okay, or would there still be stuff in the canals?
The concern, according to the company, and we have to look at the FDA's, the concern is that, yes, you can take the gutta percha out, but what happens to the dentinal tubules? All these millions of tubules inside the tooth are filled probably with toxin, probably with heavy metals, and some people say it's a concern.
Okay, well, so what about seashells? Where, when they first started finding hydroxyapatite, they said you can find this in billion-year-old seashells. What about buying seashells and throwing them in that pulverizer?
Yeah, that has been used. That's called an alloplast material. Unfortunately, clinically does not work that well in my experience. These materials did not work great, although they're coming back now. So I'm not a big fan.
Okay. And my God, that was the fastest hour I've ever done. It's an hour. That's my brand. Time is up. But Ziv, seriously, and I'm not blowing smoke up yet. I just think you're just the all-American real deal. I mean, if someone said, who's Batman in dentistry, be you. You're the full package. You're a great teacher. You're a great surgeon. You're crushing it on your courses, hands-on, social media. Anything I can do to get more of your posts on Dentaltown or an online scene, I think it'd be great marketing for you. Because I think that, like you put out those weekly videos.
Yep.
If you also uploaded that in a thread, I mean, more people. Also, when you we passed 35,000 downloads on the app, and that's why these podcasts are so huge, because they're so any sound files you have, you can upload them in our podcast system, and because what they're doing is they're driving to work and they're just plugging this into their car, and they're multi. When we were little, we were successful because we would do that rare thing and read books. But most people just can't sit there and read. But now audiobooks have passed physical books at Amazon. And the reason podcasts are so huge, Ziv, is they're all multitasking. They're driving to work, they're on the treadmill, they're cleaning the kitchen, they're washing their car. Everybody's listening to these things on headphones. So if you have any of your videos, the sound files, you can even upload those.
Funny you mentioned this. This is one. This is actually an audio program on crown lengthening. I have 6 CDs. Each one is 1 hour, talking about crown lengthening, functional aesthetics, the rational complications, how to set up your practice. So I now have a full program.
Now, do you sell that? You sell that?
That's going to be available now on crownlengtheningsurgery.com.
And how much is that?
I have to see how much they price it, but it's very reasonably priced. It includes some bonuses.
Because if you look at Walmart as distribution and Dentaltown as distribution, our business model, by the way, is we do whatever you do. If you put it for free on Dentaltown, I got 50 employees of overhead, we do it for free. But if you charge $1, we collect the money and split it 50 cents. So if you're selling that on your website for $1, you could put on Dentaltown for $2 and we'll split it. Or you could say, I'll put on the same price because you're going to get a lot more volume.
Let's talk about all these options. I mean, that's
because I feel like one of my missions is to expose more dentists. There's 2 million dentists on Earth, and they all need to know Z. You want to go by Z or Ziv, or what is your deal?
Whatever you want. Simon, Ziv, Z, hey you. It doesn't matter. As long as you call me, I feel good.
So you must be sport confused living in Germany, Israel, Canada. So are you a soccer fan, a hockey player, or did you finally convert to American football?
I just do individual sports. I just do my jogging and my swimming, and that's what I'm into. But I love sports in general.
But you love to participate in sport, not watch it.
I'm sorry?
You like to participate, not watch.
Yeah, I don't watch that much. No, not too much time.
Well, Ziv, you're amazing. This was the most exciting hour I think I've ever had. Thank you so much for what you do for dentistry, for Dentaltown, your patients. You're the real deal. Thank you so much.
Thank you, Howard. It was a pleasure being here with you.
All right. Thanks. Bye.
Take care. All the best.